Hello, everyone, and welcome to our module on tuberculosis. So, tuberculosis is a very old and ancient disease. They have even found evidence of tuberculosis infection in Egyptian mummies. The old name for this condition was consumption. And so, if you read stories from Victorian England, you will hear discussions of people who have consumption and they're talking about tuberculosis. The reason the disease is called tuberculosis is because a tubercle is a round nodule, and in tuberculosis, multiple round nodules or multiple tubercles are found throughout the body, especially in the lungs, and that's why the disease was originally called tuberculosis. The bacteria that causes tuberculosis is called Mycobacterium tuberculosis, and it's a mycobacterium, and that means that it has cell walls that contain mycolic acids. Mycobacterium are a special type of bacteria. I talk about some other mycobacteria in the infectious disease section, but here we'll focus on Mycobacterium tuberculosis. M. tuberculosis is an obligate aerobe, so it prefers the lungs, and that's why the lungs are a major site of infection with this bacteria. And later we'll talk about reactivation disease after the infection has become dormant, and this usually happens in the upper lobes of the lungs. And once again, that's because the bacteria is an obligate aerobe. M. tuberculosis is also a facultative intracellular pathogen. In particular, it will infect macrophages and replicate inside of macrophages. And so this is a high-yield little detail to remember for your STEP exams as part of the pathophysiology of how this bacterium replicates. One thing to know about tuberculosis is that it's difficult to culture in the lab, especially compared to other bacteria like staph and strep. You have to use special media, and the media that's often used to grow tuberculosis is called Lowenstein-Jensen agar. And I talk about this culture media and many other culture media in videos in the infectious disease section. Another thing to know is that tuberculosis is a relatively slow-growing bacteria in the lab. It can take 1 to 8 weeks for a culture to grow, and this has implications which we'll talk about later when you're trying to make a diagnosis of someone who may have active tuberculosis. The culture results are going to take a long time to come back. You should also be aware that tuberculosis does not stain well with the Gram stain. It has mycolic acids in the cell wall, as we've already discussed. It also has other structures in the cell wall like fatty acids and complex lipids. And because of this, it often doesn't pick up the Gram stain very well at all, or it can pick it up irregularly. And so it's very difficult to categorize this bacteria using the Gram stain. The way you can identify tuberculosis is with an acid-fast stain, and that's because it's a so-called acid-fast bacteria. So let's talk about what that means now. So acid-fast bacteria, like tuberculosis, have cell walls that are impermeable to many dyes, like the Gram stain that we just talked about in the last slide. But the bacterial cell wall will stain with very concentrated dyes plus heat. These are dyes that are lipid-soluble. They contain substances called phenols. You don't need to know all these details here, but I'm just telling you so that you've heard them. But these dyes are specially made, and then you add heat, and this will cause the bacterial wall to pick up the dye. The way you perform an acid-fast stain is you stain the bacteria with one of these very concentrated dyes, and then you rinse the plate with an acid decolorizer. And this is why these bacteria are called acid-fast stains. Tuberculosis will resist the decolorization with these acid-fast stains that are acid solvents, and this will allow you to visualize it. So this will make more sense if you look at this little cartoon on the slide here. This shows how you do a Gram stain, but over here is how you do an acid-fast stain. So in the first step, you stain the bacteria with one of these very concentrated acid-fast stains. And bacteria like tuberculosis will pick up the stain very well, even though they won't pick up the Gram stain so well. Then you decolorize it, but the acid-fast bacteria will hold on to that stain. It will become part of the cell wall. This is that step of using an acid decolorizer like we talked about earlier. Then you can apply a counter stain, and you will be able to see the acid-fast bacteria, which will have a different appearance compared to other bacteria which can pick up the counter stain. And this is very similar to what's done for a Gram stain, which is depicted here. The main difference is that you use these special, very concentrated dyes plus heat in order to get the bacteria to pick up the stain in the first step. And there are other bacteria besides tuberculosis that are acid-fast. Nocardia is another one, and I talk about many of these in the infectious disease section. Okay, tuberculosis has a number of virulence factors. Virulence factors are components of the bacteria that cause disease. So let's talk about what those are now. The first one is called trehalose dimycolate. It's also known as cord factor. This is a very abundant glycolipid that's found in the cell walls of tuberculosis. It contains sugar molecules called trehalose, but also mycolic acids, and that's why it's called trehalose dimycolate. And this does a number of things. One of the big ones is it helps it to evade the immune response so that it can survive inside the body. It also leads to a lot of inflammatory effects. It activates macrophages, which leads to granuloma formation. We'll talk about granulomas in just a minute. It also triggers cytokine release, especially TNF alpha. Another virulence factor is the presence of sulfatides. These are glycolipids that have sulfur molecules on them. They're called sulfated glycolipids. And they're also found in the cell wall, just like cord factor. And these can inhibit the fusion of phagosomes and lysosomes so that the bacteria, once it gets inside of macrophages, it doesn't get destroyed by being consumed by a lysosome. And then finally, tuberculosis has an enzyme called catalase peroxidase, which is usually abbreviated CatG. This is an enzyme that resists oxidation inside host cells like macrophages. It's also a very important enzyme because it converts the drug isoniazid or INH into its active form when you use this drug to treat tuberculosis. And I'll talk more about INH and other treatments for tuberculosis in this video and the second video on TB. The transmission of tuberculosis is through the air. You inhale the mycobacteria, and that's how you become infected. And so this means that patients who are hospitalized with active tuberculosis need to be placed on airborne precautions so they don't spread the bacteria to other people. And I talk about what airborne precautions are in the videos on quality and safety. There are a number of different precautions that are taken in patients who may have an infection. Airborne precautions are the ones that are used for tuberculosis. So the way you become infected is that someone who has active tuberculosis in their lungs, they will cough or sneeze, and the bacteria will be inhaled by an uninfected person. And for this reason, tuberculosis can spread rapidly in crowded areas, especially among people who may be malnourished and have an ineffective immune response. And this is part of the reason that tuberculosis was so common hundreds of years ago when patients lived in poor sanitary conditions in very crowded areas. If you're exposed to someone who has tuberculosis and you inhale some of the mycobacteria, let's talk about what the results of that exposure will be. First of all, you should know that most people who are exposed will not develop active disease. Instead, the infection will either be cleared or it will be contained. And when you have a contained tuberculosis infection that is not causing symptoms, we call this a latent infection. And there are many people who have been exposed to tuberculosis who now have a latent infection that's asymptomatic. Only a small proportion of people who are initially exposed to tuberculosis are going to go on to develop active disease. So that brings us to a discussion of primary tuberculosis, which is the active infection that a small number of people get on initial exposure to the mycobacterium. This is mainly a disease of childhood or chemotherapy patients, and the reason it happens in these groups are because these groups have an ineffective immune response, and so when they are first exposed, they sometimes develop an active symptomatic infection compared to other individuals who may be able to contain or clear the infection. The symptoms have a gradual onset over weeks. The symptoms include evidence of infection like fever. There's pulmonary involvement because the bacteria is inhaled into the lungs, so patients can develop cough, pleuritic chest pain. They can also have fatigue and arthralgias. All of these things are relatively nonspecific signs of a respiratory infection, so you have to have a high index of suspicion to know that someone may have these symptoms caused by tuberculosis as opposed to a virus or some other much more common bacteria. Let's talk about the pathophysiology of what happens inside the body on initial exposure to tuberculosis when patients develop an active infection, meaning they develop active primary TB. So during the first week following exposure, during the first week of infection, the tuberculosis bacteria will infect macrophages. This is a very high-yield detail to remember about how this infection progresses. The bacteria are phagocytosed by macrophages, but the macrophages are unable to kill the bacteria, so intracellular bacterial proliferation occurs. Eventually, when there are enough mycobacteria inside the macrophage will die, and it will spill all those tuberculosis bacteria out into the lungs. And sometimes primary tuberculosis infection is broken up into stages. When you do it that way, stage 1 is when the macrophages are infected, and stage 2 is when the tuberculosis bacteria proliferates. And all of this occurs roughly during the first week or so of infection. In weeks 2 to 4, the infection leads to granulomatous inflammation. Granulomatous inflammation is a special form of chronic inflammation. I talk about it in detail in videos in the pathology section. But the hallmark of granulomatous inflammation is the formation of granulomas, and I'll show you a picture of what these look like in a minute, but they form usually in the lungs in patients who have primary tuberculosis, and this is sometimes called stage 3 of primary TB. What's happening in this phase of the infection is the cell-mediated immune system is trying to control the tuberculosis infection, but it can't eliminate it from the body, and that's what leads to chronic inflammation in the form of granulomatous inflammation. Some of the key things to know about what's going on an immunological level here are that, first of all, CD4 positive T cells are activated and they are inducing a Th1 response. Lots of interferon gamma is being secreted. And all of these things here go on to activate macrophages and cytotoxic T cells, which are going to try and contain or clear the infection. Okay, let's talk about granulomas, which once again I discuss in much more detail in the pathology section. But granulomas are a structure that forms as a result of granulomatous inflammation. This is a picture of a granuloma on the slide here. You can see that you have all these white blood cells here. These are the little black-purple dots that are surrounding this circular structure. In the middle here, you have necrotic tissue, and that's what happens in tuberculosis. You get caseating necrosis in the middle of these granulomas. If you look at the cell types that you can find inside granulomas, you will find macrophages, but some of them will transform into epithelioid cells. So epithelioid cells are macrophages, but they take on the appearance of an epithelial cell. That's why they're called epithelioid cells. And this is what can happen to macrophages after they've been infected by tuberculosis. And then some of these epithelioid cells will fuse together and they will form cells called Langhans giant cells. And so both these cell types, in addition to macrophages, can be found inside granulomas in tuberculosis. And I mentioned this before, but this is a high-yield little detail to remember for your STEP exams. This is a T-cell mediated process. It's an example of a delayed type hypersensitivity reaction, a type 4 hypersensitivity reaction. That's what leads to formation of these granulomas. When the lungs become infected with tuberculosis, the classic finding on chest X-ray is hilar lymphadenopathy. So let's talk about that now. This is a classic finding in tuberculosis, although you should be aware that the chest X-ray is often normal, and so the absence of this finding does not mean that the patient does not have TB. Hilar lymphadenopathy means there's enlargement of the hilar lymph nodes. So the hilum is an area of the lungs where the bronchial vessels enter. It's found to the left and right side of the trachea. And so if you look at this chest X-ray on the slide here, this is the trachea right here. It divides into the right and left main stem bronchi, and you've got these enlarged, sort of hazy, cloudy white structures here. These are the hilar lymph nodes. They're enlarged, they're very prominent. That's hilar lymphadenopathy, classic finding in tuberculosis, although not always present. This finding occurs as early as 1 week after infection, and then it will resolve slowly over months to years once the patient either clears or contains the infection. Besides hilar lymphadenopathy, another classic pathology finding in tuberculosis infection of the lungs is the presence of Ghosn foci. So let's talk about what those are now. So this is a pathologic finding associated with primary tuberculosis infection of the lungs. It's usually described as something you see on gross pathology when you examine the lungs post-mortem, but you can also sometimes see these Ghosn foci as a focal lesion on chest imaging. This is a picture of one right here. You can see there's a small white nodule. That's a Ghosn foci. Down here is what one looks like on gross pathology when you examine the lungs post-mortem. These little foci are caused by granulomas. They're usually subpleural, so they're just beneath the pleural layer surrounding the lungs. They're usually found in the mid to lower lungs, sort of like this one here. This is sort of in the mid lungs here. So when patients have one of these little small foci of granulomas, we call that a Ghosn foci. We call it a Ghosn complex when there's evidence of Ghosn foci plus lymph node enlargement on the same side as the Ghosn foci. So for example, if you had this path finding right here associated with an enlarged lymph node on that side of the lungs, you would call that a Ghosn complex. And then if you have one of these Ghosn complexes, but the Ghosn foci has become calcified, then that's called a Ranke complex. Okay, let's go back to talking about primary tuberculosis, which remember is an active infection of the lungs caused by initial exposure to the tuberculosis bacteria. And let's talk about how that infection usually resolves. So most patients, about 90% or so, will control the infection. The disease will heal, meaning that the inflammation will resolve and fibrosis will be left behind. Sometimes tuberculosis bacteria are completely cleared from the body so that no bacteria whatsoever remain behind. But more often what happens is the infection enters a latent phase. The bacteria become walled off, but they are still present and potentially can grow inside the lungs, even though they're no longer actively growing and causing symptoms. When this happens, when the infection enters this latent phase, immunity develops, and patients will have a positive PPD test. And I talk about the PPD test in the second video on tuberculosis. Now, all this stuff right here is what happens to most patients, but a small percentage, about 10% or so, have expanded illness beyond the lungs. This is often referred to as miliary dissemination. It's more common in patients who have some type of immunocompromise, either advanced HIV disease or chronic kidney disease or diabetes. But if something like this is present, then patients can have primary tuberculosis involving the lungs, and it can eventually spread to other parts of the body. So let's talk about miliary TB, which refers to the hematogenous spread through the bloodstream of tuberculosis from the lungs. It's called miliary because patients who develop this usually have diffuse lung infection, and the infection in the lungs on chest X-ray can look like small millet seeds, so that's why it was initially called miliary TB. But it basically is a term that's used to refer to tuberculosis that is spread throughout the body via the bloodstream. This can happen because a primary tuberculosis infection progressed. It can also happen because someone who had a latent infection had that infection reactivate, and that in turn spread throughout the body. And miliary TB is famous for the fact that it can infect almost any organ in the body. This is exceedingly rare in the modern era, but 50 or 100 years ago, when there were no good treatments for tuberculosis, patients would develop miliary TB, and it would spread to the bones and the liver. It could spread to the central nervous system, causing meningitis. Patients would die sometimes from pericarditis of TB involving the heart. It could also spread to the skin. But all these things, luckily, are very uncommon in the modern era because we have effective treatments for tuberculosis infection. Let me just mention a couple special elements of miliary TB that you should be familiar with. The first one is called Pott's disease. This is what we call it when miliary TB leads to a spinal infection with tuberculosis. In other words, osteomyelitis or bone infection of the spine and spinal processes caused by TB. So this can present with many common features of spinal osteomyelitis, things like back pain, fever, night sweats, and weight loss. On imaging, you can see a lesion in the spine, and if you biopsy it, you can find evidence of tuberculosis. That is Pott's disease. You should also be aware that miliary TB can potentially lead to tuberculosis infecting the pericardium. I mentioned this on the last slide. If this is left untreated, eventually the pericardium can become fibrotic and it can restrict the heart function. And this leads to constrictive pericarditis, which is a pericardial heart condition I talk about in other videos. Okay, let's talk about reactivation TB. So this occurs when there's reactivation of a dormant or latent tuberculosis infection. In other words, the immune system has controlled but not cleared the infection from the body. It can become latent and lie dormant for many years or even decades, and then it can potentially reactivate, especially in the setting of impaired immune system function. So when tuberculosis reactivates, it usually does so in the lungs. So this leads to symptoms like cough, but also the chronic inflammation leads to symptoms like weight loss and fatigue. Patients can develop fever and night sweats. There can be chest pain from lung inflammation that irritates the pleura and the chest wall. On imaging, the findings in reactivation TB can appear a number of different ways, but sort of the classic appearance is what's shown on this slide here. Notice that the white hazy material is mostly in the upper lobes. That's where tuberculosis likes to reactivate, the upper lobes, and that's because, as we said before, it's an obligate aerobe. There is also often cavitation of the lungs, and you can see a cavity right here, this circular black spot here. That's caused by caseous and liquefactive necrosis due to the inflammation in the upper lobes caused by tuberculosis reactivating. And when these cavities form, they can erode the pulmonary vasculature, and that can lead to hemoptysis. So reactivation TB usually develops slowly over several weeks. So someone who presents with weeks of pulmonary symptoms that look like what's shown here, a chest X-ray with upper lobe lesions maybe showing cavitation, all those things should make you think that this person may have reactivation tuberculosis causing an active pulmonary infection. I mentioned this before, but reactivation of tuberculosis can occur anytime the immune system becomes compromised. So as I said earlier, many of us when we're initially exposed do not become symptomatic and the infection is controlled and becomes latent. But years or decades later in our lives, if we develop some form of immune compromise, then tuberculosis can reactivate. So this could be advanced HIV infection. There are certain drugs that inhibit the effects of TNF-alpha. These are used in autoimmune disease. These are drugs like etanercept and infliximab. And so many patients who are placed on these drugs are actually tested for latent TB before treatment, and that's because reactivation could occur. Also, any patient who's had a solid organ transplant, like a kidney, for example, these patients often are on powerful immunosuppressants to prevent organ rejection, and that can compromise the immune system, leading to reactivation TB. Let me briefly mention aspergillomas, which are fungus balls that grow inside the lungs. These are collections of fungal growth that are caused by the fungus Aspergillus fumigatus. This is a non-invasive form of aspergillosis, meaning infection with aspergillus. Usually, this form of aspergillus does not cause disease, but it does like to grow in preformed cavities, and pulmonary tuberculosis is the most common association with the presence of a fungus ball aspergilloma. These can be asymptomatic and seen on imaging, but they can also cause hemoptysis if the growing fungal infection leads to erosion of blood vessels. You diagnose these fungal infections by imaging and a sputum culture that grows the fungus. Sometimes they're treated with simple observation, sometimes they require surgery. The most important thing to know about these is just that they can occur in patients who have pulmonary TB, because remember, patients with pulmonary TB like to develop those cavities in the upper lobes of the lungs, and these cavities can become a place where this form of the fungus aspergillus can grow. And so in the infectious disease section, I talk about aspergillus in much more detail. It can cause an allergic reaction called ABPA. It can also cause an invasive fungal infection, and then it can cause the formation of an aspergilloma, which is a fungus ball, and that usually occurs in patients who have pulmonary tuberculosis. I'll finish with this slide just summarizing all the things that can happen after exposure to tuberculosis so that you can keep them straight in your mind. So remember, exposure occurs through inhaling the bacteria into the lungs. Some of us will completely clear this infection, meaning that the immune system will eliminate tuberculosis from the body. This can happen with us being entirely asymptomatic, and we can never know we were even exposed. Other patients will develop a primary active lung infection. That's called primary TB. This usually occurs in children or patients on chemotherapy or patients who are, for some reason, immunocompromised. And then other patients will develop a contained or latent infection. The bacteria will still be present in the body, but the infection will be contained. This is entirely asymptomatic, and patients can live indefinitely with a latent infection. But then some patients years later will have reactivation of that latent infection. This often occurs in the setting of immunocompromise, and this will lead to another active lung infection that is reactivation TB. And then primary or reactivation TB, either of these two forms of active lung infection, can potentially spread hematogenously throughout the body, and that's called miliary tuberculosis. And that concludes our module on tuberculosis.